welcome back. So we've taken care of our hemorrhage. We've got our chest seals on. We've got our packing in. We've got our tourniquets. We've done our blood sweep. Everything is copacetic in that regard. Now we're going to maintain an airway. Now, most time airways is not a big issue when it comes to trauma, unless it's chemical or burns or something like that that would cause the trachea to swell and shut. But we have what's called a nasopharyngeal, or a nasal airway. And these are different sizes. This is a 28 French. And how you measure is you take this flared portion, you're going to put that at the tip of his nose. This end should be at his ear, the tip of his ear. And I'm going to come in where you can get a better look at it. It'll also come with some lubricating jelly that is non-petroleum, so it won't burn. It's water soluble. This flared portion is what's going to be sticking out of the nair. This is what's going to go into the nair, go behind the tongue. So if the tongue falls back, you'll still have an airway open. If you'll notice, it's beveled. The bevel goes toward the septum. That's your dividing between your two nairs. If you don't have lubricating jelly, stick it in your mouth, lick it real good, shove it in. It'll still work. And that will keep your airway open. So we've stopped our hemorrhage. We've got a way to maintain an airway. Now we're waiting on the cavalry to get here. We're waiting on EMS. But while we're doing that, we're monitoring. So we're always monitoring. And I'm probably right downhill. But now we're monitoring what happens if he stops breathing. All right, now this is where it turns back into CPR, basically. It doesn't really matter why he did. Chances are it was hypothalamic shock or hypothermic shock due to blood loss. But it doesn't really matter. We're going to treat it the same way. So we've taken care of the hemorrhage. We've got our chest seals taken care of. We've got an airway open. Now let's assume that we don't have a nasopharyngeal, or we haven't placed it yet. But all we know is he went unresponsive. So first thing we're going to do, this is where CPR starts. So everything above this is directly related to trauma. Everything below is CPR, whether it's trauma or a medical emergency. So let's, for time's sake, just assume this is a different patient, okay? We're not worrying about trauma now. This is a medical emergency. You're in church or you're at the restaurant or whatever, somebody becomes unresponsive. First thing you're going to do is check for responsiveness. Hey, talk to him. He's not saying anything. If you really want to get fun, take a ear and twist. We won't get into AFPU, alert and oriented, responds to verbal stimuli, responds to painful stimuli, unresponsive. We're just going to say he's unresponsive. So the first thing we're going to do is we're going to open an airway. So what we're going to do, we're going to do the head tilt, chin lift. Now, again, if it's trauma, and we've had a nasopharyngeal, it's already in.
Do I hold him down?
Yeah. If it is, then we know our airway's open. But now this part's going to kick up on us, and I'm just going to let it kick up. So what we're going to do is we're going to do a head tilt. So we're going to take this hand, put it on his forehead, tilt down, take these two fingers under the chin, open it just a little bit, and when we get down here, I'm listening for a breath, and I'm looking for chest rise. I have neither one. So he's not breathing. Now there's what's called agonal breathing. And what agonal breathing is this. All right, that don't count. That ain't moving in. Well, it's moving air for me, but I mean, he's not breathing. So we're going to give 2 rescue breaths. So we're going to open the airway, and I'm not going to because this will kick up. Pinch his nares. We're going to pinch his nose off, and we're going to give 2 breaths. So and we're just doing it to get chest rise. So it's over a second. Then we're going to take our fingers, We're gonna take our fingers, put it on the trachea. We're gonna slide it back to us to this groove right here beside the trachea. That's your carotid artery. Do we have a pulse? We do not have a pulse. So if 911 has not been called, 911 is called now. We're gonna assume that we do not have an AED. If you are a church, if there's any way financially possible, when we got ours, I want to say it was $1,800. Again, time is of an essence. At the hospital, if we find somebody in cardiac arrest, we want to shock them within the first 2 minutes. Survival rates go significantly higher with less long-term damage. So, but assuming now we do not have an AED, but we have called 911. So now, because the heart is not beating, or the heart is not beating efficiently, maybe it's in what's called ventricular fibrillation, where the heart's just quivering. It's not pumping. We're gonna pump forward. So we're gonna take your ring finger, you're gonna hit the rib cage, you're gonna go up to the sternum, right here, and you will feel a triangle. That triangle is your xiphoid process. It's just above your solar plexus. You're gonna lay these two fingers down. This hand, the palm, is gonna go just above those fingers, and then you're gonna pull your hand back. And you're gonna do compressions. You're gonna compress 2 inches. You have to compress the heart. If you're sitting up here doing this business, and the heart's just doing this, you're not pumping, okay? We're not getting oxygenated blood to the brain. 2 inches. Now this is too high, because what I would really want to be is over like this, and I'm not pushing with my arms, I'm pushing with my torso. We're compressing at a rate of 100 to 120 beats per minute. The easiest way, for those of you who are like me and a little bit older, if you're a fan of the Bee Gees, which I am not, you in your mind will be doing staying alive. Staying alive, staying alive. That's how fast you compress. In my situation, I use Queen. Another one bites the dust. Dump, 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 dump. Another one bites the dust. That's how you know that you're compressing at a quick enough pace. But in my case, I have a tendency to go too fast. So I'm compressing the heart, but I'm not coming to full recoil where that the heart completely expands, which allows blood to get into it. So that when I compress again, I'm compressing blood into the body. If I'm going too fast, I'm not letting the chambers fill with blood, and I'm not doing any better than if I wasn't compressing it up. We're going to do this at a rate of 30 to 2. You'll do 30 compressions, 2 rescue breaths. 30 compressions, 2 rescue breaths. You will do a series of 5, or a cycle of 5. That will give you 2 minutes. In 2 minutes time, you're going to check, do you have a pulse? If not, you're going to continue. How long do you do CPR after you start? You do it till you can't do it anymore and you fall out. The longest I've ever done compressions was 41 minutes. The poor gentleman was dead before we started, but we coded him, and 41 minutes later we quit. The next day I couldn't brush my teeth, my arms were so sore. So now ideally you have help. So if Virginia was here to help me, she would be doing the rescue breaths, I'm doing compressions. After 5 rounds of rescue breaths and compressions, we're gonna swap. It's gonna give me a break. So I'm gonna do the rescue breaths, she's gonna do the compressions. And we're gonna do that till help arrives. And that is, I didn't write it on the board, but we have opened our airway, we've done respirations, and we've done circulation. Oops. Okay. Now, back to the medical emergencies. And we're gonna get the infant out. Oh, one thing I need to talk about too. When we talk about tension pneumothorax, there is what's called this is a chest dart. This is a decompression drill. You'll go to this is just for information. I'm not really teaching this per se, because this is a little more involved. But what you would do is, if the air has built up in that pleural space, the trachea has deviated. what you would do is you could take one of these, you go to the third intercostal space. The intercostal space is the space between the ribs. Your first rib, you can't feel. It's under your collarbone. So it comes from your collarbone. You got a rib right here. Between the second and the third is your third intercostal space. And you're gonna put a dart, or put this needle in line with the nipple. And what it does is, it's just like puncturing a balloon. It will allow air to escape, which allows the lung to expand where he can breathe. But that's a little more complicated to really get into. So what we look at is, now, IVs. If you're trained and you've got the equipment, definitely get us a couple large bore IVs. Do not start fluids. You can do what's called blow the clot. You do not start fluids till you lose pulses in all four extremities. And hopefully by that time, EMS is already here. The reason I'm saying if you have the training and the equipment, go ahead and do the IVs, because as fluid loss becomes worse, it's much harder to get the vein. Now, we can do a bone needle or something like that. But ideally, if we've got two large bore, 16, 20, 18 or 20s in the 8Cs, then we can push fluids if we need to. And the final thing we're going to talk about, and we'll also be bringing the infant in, is airway obstruction, where not necessarily, it could be food or something like that, especially with an infant. If an infant goes into cardiac arrest, 99.99999 times out of 100, it is related to an airway obstruction. It could be a grape, hot dog, a marble, whatever. So what we're going to do, again, we're checking for responsiveness. Hey, look at me. Unresponsive. I'm going to open the airway. So it's the same thing. Head, tilt, chin, lip. Okay, I'm not hearing any air. I'm not seeing chest rise. I'm going to give 2 rescue breaths. Be very, very, very careful with an infant. If you breathe too hard, it's very easy to just blow the base of their lungs out. So rather than pinching the nose off, we're going to take our mouth, we're going to cover the nose and the mouth. And we're just giving enough air over a second to get chest rise. Okay, I can't get air in and I'm not having chest rise. So I'm going to check the airway one more time, make sure I've got position properly. Still ain't. That means I've got an airway obstruction. I'm going to look. I'm not going to do a blind sweep. I ain't going to just stick my finger in there because I don't want to push it further down. So what I'm going to do, which I've already called 911 or somebody's called 911, I'm going to take the infant like this and I'm going to sit down because it works better and I can demonstrate it easier. Rest the infant with the head down on your leg. We're going to do 5 back slaps. 1, 2, 3, 4, 5. Take your other hand, cradle the back of their head with still keeping their head down. Roll. We're going to do 5 chest thrusts. 1, 2, 3, 4, 5. Now we want gravity to help us. Once we do that, we're going to try the rescue breaths and we're going to do compression. The compressions for an infant's a little different. What you're going to do is you're going to look at the nipple line, take 2 fingers, and it's 1, 2, 3, 4, 5. And you're only going to go an inch, inch and a half deep. Now, you're going to do 15 to 2 instead of 30 to 2, unless you have 2 people. If you've got 2 people, then you'll do your compressions like this. You'll wrap the baby with your hands. Your thumbs will be in the right place. And it's 1, 2, 3, but it's 30 to 2, and then the other person will give rescue breaths, okay? But you're going to do that, and then you're going to open the airway, and you're going to listen and look for chest rise, listen for air. You're going to look for the object. If you can see the object, you can get it, absolutely get it. If not, we're going to keep going. But we're not, again, going to do a blind finger sweep. And we're going to do this till help arise, okay? Now, on an adult, y'all have heard of the Hamilton movement. And that's what we're going to do. Universal sign of choking. Yeah. Now, if it's a child or an infant, and they get something hung and they're screaming. The airway is not occluded, everything's, well, I'm not gonna say everything's cool, but they're all right, they're breathing. All right, so this guy comes up, he's a restaurant, and he's giving it this. Boss, you okay? I'm here to help. So, and it's not very often that you're taller than me, but I'm gonna take this hand, I'm gonna come around just under his I-4 process again. Take this hand and grab it, and then I'm doing this. I'm thrusting in and up, and I'm doing that till he expels whatever is blocking his airway. If it gets to the point that he becomes unresponsive, I'm gonna let him come back into me, and I'm gonna lay him on the floor, open the airway, look. If I can see it, I'm gonna get it. Again, no blind finger sweeps, and I'm doing CPR. Even if I'm not giving him rescue breaths that are effective, he had oxygenated blood. And if I could just keep the oxygenated blood circulating, and his circulatory system is still going to the brain, and that will give us time till we can do something else, if that makes sense. But we're back to CPR. It's compressions, 30 to 2. Okay, now, we've done it. We're back to our trauma. We have stopped the bleeding. He's got a pulse. He's breathing on his own. Good there. So we're going to put him in left lateral recumbent. So we're going to turn him kind of on his side, lay it on this arm, and I'm going to do it standing up. But we're going to have this arm out and this arm up like this, laying on his left side. And that's left lateral recumbent. Now, what we're going to be concerned about is, now, is either hypovolemic or hypothermic. Hypo just means that we're low. Hypotension, low blood pressure. Hypoglycemia, low blood sugar. Hypertension, high blood pressure. Hyperglycemia, high blood sugar. So hypovolemia is low volume because of fluid loss. So if it's not contraindicated, we're going to put him in reverse Trendelenburg. So we're going to have his head lower than his feet. Now, if he's got pelvic injuries, we're not going to do that. But the reason being, the blood in his lower extremities, I'm not worried about these right now. I'm worried about him. And if this blood that's here, if I can have it up here where his vital organs, his brain is, that's where I want it. The other thing is hypothermic. And hypothermic is a low blood body temperature. So what I'm going to do is I'm going to cover him. If I can keep him off the ground, if I can put something under him safely, that's what I'm going to do to insulate him from the cold ground. Keep something over the top of him to keep him warm. And we're going to continue to monitor the situation. Even though he was in, we got him back. He may go into cardiac arrest again.
18.
How much?
18.
Okay. So this one has been long, but we've only got one more thing to cover. So this is not fun. If there's more than one casualty, we have to do what's called triage. Triage is a French word, and all it means is to sort. So what it looks like is we're going to group these people into 3 categories. They're the ones that, I hate to say it, they're already dead. There's nothing we're going to do that we have the ability to fix it. Maybe the brain is showing, their head's gone, or part of the head's gone. Maybe it's traumatic amputation where from the waist down they're gone. There's nothing we can do to fix it, not in that time. They're the ones that need to be fixed, but they can wait a minute. They're wounded, but they can hold off just a second. It's not life-threatening right this minute. Then there's the ones that we either get them now or we lose them. Now, how do we do this? It's a very simple matter. We've got them in a casualty area, or we've come into the room. It's an active shooter event. It's in the sanctuary. What we're going to do is, I want everybody who can hear my voice that can ambulate. I want you to move from here to here. Okay, that's that group that, yes, they have to be addressed, but it's not going to be in the next 30 seconds because they're responsive and they're ambulatory. Now there's the ones that can't move, but they're still responsible. So now, what I'm gonna say is, all right, now, who of you can hear my voice, but you can't move, raise your hand. Or nod your head, or whatever you can do. Those, again, can wait just a little bit. It's the ones, then all you have left is the unresponsive. Now, you either in the unresponsive, you only have to split them up into two categories. They're either gone, or if I don't do something right now, they're gonna be gone. So I've got to get an airway open, I've got to stop hemorrhage, whatever. Now, ideally, we have trained people, so you're not the Lone Ranger, you've got other people helping. So you take care of the ones that are unresponsive, but treatable. Then you get the group that is responsive, but they're not able to move. And then last you get the group that was responsive and ambulatory. And you do it in that order. Now, let's say it's you and your family. It's you and your child. You're wounded and your child's wounded. You treat yourself first. If you let yourself bleed out, there's nobody to take care of your child. It's just like being on an airplane. Oxygen drops down, you put your own oxygen on, then you put it on your child. Same principle. Would I be able to do that? I'm not sure. But that's what we look at. So I apologize for being so long-winded. We have just skimmed the surface, but hopefully this will help you at least be aware and what can be done, what needs to be done. So, you know what I'm gonna say for us, comments, questions, criticism, we just put them in the comment box. If you found it helpful, I would ask you to pass it on to other people. Follow us so that you get the notifications when the videos come up. And as always, I remain your humble and obedient servant, John Ossenberg. Thank you for your time.